Namaskar dosto, good evening friends. I am Dr. Sanjay Kalra, your friendly and familiar endocrinologist. And you are watching Dr. KK's Med Talks, Mondays with Dr. Sanjay Kalra. आज के हमारे नॉन स्टॉप शो का 1088वां 1088th एपिसोड है. Let's have the headlines for the day. Obesity and high glucose levels. These play an ever-growing role in ill health, finds a study, and these are two determinants of disease which seem to be just increasing and increasing in their impact on ill health. According to the WHO, at least 1 in 8 people on earth live with obesity. हर 8 में से एक मोटापे के साथ जी रहे हैं. और ये जो आंकड़ा है ये बढ़ जाएगा. By the year 2035, it will have become 1 out of every 2. Over half of the global population will be living with overweight or obesity, according to World Obesity Federation projections. There is an inequality epidemic as well, and teenagers from low-income families have a higher risk of obesity. तो पहले माना जाता था कि ओबेसिटी जो है, मोटापा जो है, ये अमीर घरानों की बीमारी है, पर अब जो टीनेजर्स हैं, जो गरीब घरों से हैं, लो इनकम हाउसहोल्ड्स, वहां पे ओबेसिटी बढ़ रही है. So there's an inequality paradox. And the worst paradox is that of unawareness. 1/3 of all Indians with obesity fail to recognize their condition. उन्हें पता ही नहीं चलता कि वो मोटापे के साथ रहते हैं. And there is widespread misconception which leads to delayed treatment. Now armed with these headlines, let's go to our topic for today. आज का टॉपिक देखते हैं क्या है. Obesity and healthy living misconceptions, common misconceptions. तो यही तो केके मेड टॉक्स का काम है, ये हमारा उद्देश्य है. This is our aim and ambition to dispel these myths and misconceptions. And for this, we have one of the most dynamic endocrinologists of our country and the region. A warm welcome to Dr. Lakshmi Nagendra. Warm welcome, madam.
Thank you, sir. Thank you for this opportunity to speak on this very interesting topic that is close to my heart. Thank you.
Thank you so much. Allow us to introduce you to our KK Med Talks family. Dr. Lakshmi Nagendra is a distinguished endocrinologist at the JSS Medical College, JSS Academy of Higher Education and Research, Mysore, India. Extensive expertise not only in clinical endocrinology, but also in academics and research. So she makes India proud by her stellar contributions across the world. And apart from all the other aspects of endocrinology that she's involved in, two of our focuses are, one is bone and mineral health, bone health, and the second is obesity. So warm welcome, madam.
Thank you, sir. Thank you, sir.
Good evening, coming to you from across the country, Swapna Jain, madam, who is a leading advocate for healthcare, healthy living with obesity, and you will find her posts on X, which was earlier called Twitter. You will find them very useful. Recently, she compared living with obesity with the mutual funds, with investments. And that was a beautiful way of looking at the disease and its treatment. So thank you, Jan, madam, for teaching us that method of looking at disease. Then we also have Aditya Panu, who is a very young and handsome boy from Haryana. He sends you his greetings. And Dr. R.S. Pawar, sir, he's also sending you his greetings. So our topic for today is misconceptions about obesity. But before we move to that, madam, what is obesity?
So this itself has been a topic of debate, as you know, sir. So we have the recent, Lancet paper which just came out in, a month ago, redefining, actually asking what obesity is. So obesity has been, described by many things. So the age-old cutoff to define obesity was BMI, as we all know. But we know that that has a lot of problems and that has a lot of limitations by itself. So we say, like, we take a threshold BMI, say in Asians it is 27.5, in non-Asians it's much higher than that. So obesity can be defined by one BMI, but we have found many drawbacks to this, because in Asia, as we know, we are thin fat Indians. So BMI, going by BMI, we may not be fitting into the definition of obesity, because we have increased fat mass percentage compared to lean mass percentage, and BMI may be still normal. But that's one way of looking at it. The recent Lancet paper says that you define obesity as preclinical obesity and clinical obesity. So we know that obesity can lead to a lot of organ dysfunction, and if you have obesity with organ dysfunction, you can call it as clinical obesity. And if you have excess body fat who have normal organ function but are at increased risk of future health complications, then that is preclinical obesity. So these are all the definitions that we have today, but the most common that we use, in spite of all the limitations, are BMI. But waist circumference and body fat percentage, all of these can also be good indicators of obesity, especially in Indians.
So what's coming across is that there is a misconception regarding the definition of obesity itself.
Correct.
So, so this new discussion that is going on, ma'am, and we welcome Dr. Anil Shinde, senior physician from Bangalore City. Dr. Anil Shinde has contributed immensely to medical care, diabetes care across India through his senior position in the industry, and now he is in private practice. So he sends you his greetings. But so, madam, let's sort of sort out this particular misconception. The new discussion that is going on, let's ask two pointed questions. First of all, is it something that we have learned just now, or is it old wine in new bottles? And the second thing is, whatever new things or supposedly new things the commission says, is it that we are supplanting or replacing BMI with newer methods of diagnosis, or are we strengthening BMI with newer methods of diagnosis?
So thank you, sir, for this very relevant question. So I would say it is old wine in a new bottle. We knew all the way that obesity does cause organ dysfunction, and this is not anything new. But I disagree partly with this classification. I will tell you why. Because if we have only two stages, that is preclinical obesity and clinical obesity, uh, and not like certain stages like the Edmonton staging system for obesity, how are we going to get up and treat? Like if you say somebody that you don't have clinical obesity but you have preclinical obesity, that means you already have increased body fat and you're already at so much high risk for organ dysfunction. So that person may again have that misconception that I have time to go to clinical obesity till I start taking things seriously. So I don't think that this is a very good classification to use. We need to have a better classification, and of course this is old wine in a new bottle.
So, for those of us, including me, who sometimes get confused about all this new discourse, so many things going on, obesity has not changed. It was excessive adiposity even earlier, and it remains excessive adiposity even today. We are trying to find better methods of diagnosis, but that doesn't mean that the BMI is a bad method and we should stop doing it. So we will continue doing checking BMI. We will continue monitoring BMI, that is gold standard as of now. And of course, we will keep on trying to explore newer ways, both investigations and anthropometry. And even when it comes to anthropometry, let's ask Madam a question. So there are limitations in BMI checking, but in general, how accurate and how standardized would BMI checking be as compared to waist and hip circumference checking? How standardized, how accurate would both of these be across India, across the world?
So, as you know, sir, like BMI has been the standard to report obesity. Like if we see all the papers that are on obesity, if somebody is doing a drug trial for obesity, then they are looking at BMI and not the waist circumference. So BMI is a very standardized and age-old method to diagnose obesity, and BMI is easy to calculate as well, and we are all doing that in our clinics as well. Simple formula to use for BMI. But waist circumference I think is very important in our setting, because I see many patients who are normal, by BMI. Like how we classify the normal BMI, they might be fitting into the normal BMI, but they have increased waist circumference. For example, somebody can have a BMI of 22, but can have a waist circumference of 92 or 93. So then that means that by BMI, this patient has, is not obese. But when you use waist circumference, then that person has obesity and is therefore at higher risk. I mean, carries all the risks of obesity, all the complications that come with obesity. So both are easy to use, but we are all so tuned to using BMI. But when I see the typical phenotype, you see the thin fat patient who has all the complications of diabetes, but he's not um, obese by BMI. Then we look at the other parameters. But I think waist circumference is a very easy anthropometry tool to use in our clinics, but somehow we've been so used to BMI. I'm trying to incorporate waist circumference in my clinic for all patients now.
And there are other challenges as well. I remember once from my MD days reading a journal article which said that there were 14 methods of checking waist circumference. And I'm sure ingenious doctors would have increased that number by now. It will certainly be more than 14. The other thing is, depending upon the kind of clothes that you are wearing, the kind of privacy or otherwise that you have in the healthcare setting, how cooperative you are. Are you holding your breath properly, taking it in, taking it out? So all these things can also impact waist circumference. So it is an objective measurement, ideally, but practically it might be quite subjective. You might get a lot of error. And with BMI, with body weight, the chances of error are less.
Correct.
So, Dr. Lakshmi, we've sorted out this thing about misconception about the diagnosis of obesity. So, BMI is there to stay, and we will keep on working, we'll keep on trying. If you do focus on waist circumference, make sure that it is checked properly and make sure that everything is done in a very objective manner. But let's move on to another term and see if there is any misconception around this. Obesity versus adiposity. Now, in English, these are different words. हिंदी में शायद एक ही शब्द होगा मोटापा फॉर ओवरवेट फॉर ओबेसिटी एंड फॉर एडिपोसिटी बट एडिपोसिटी की एक ट्रांसलेशन हो सकती है कि चर्बी ज्यादा है यू हैव मोर फैट that is adiposity. So in English, would you try to sort of delve into these obesity and adiposity? Are they always the same? Do they overlap? Can you actually have any kind of syndromes in endocrinology where you have adiposity but no obesity?
So I remember that you gave me a talk on this about 2 years back. Adiposopathy or obesity, are they the same? So we looked, even I was very surprised to look at the differences of, between the both of them. So they are not the same. I was surprised to know. So, for example, there is this BMI paradox also, right? Like for example, in heart failure. So we used to think that not all fat is bad. Some patients also can have healthy obesity as well. So that was one concept that came about a few years back, that not all fat is bad. Can all fat be bad? So we were debating about that. There are controversies, and there were a lot of other counter arguments for the BMI paradox as well. So they were looking at the obesity by BMI, and it was getting the result was contrary to what was expected. But then again, when they looked at other markers of obesity, like waist circumference, so they did see that it was not a paradox. Actually, those people had worse outcomes than normal weight people. So there are a lot of counter arguments to the obesity paradox. But I think the argument now, in later years, now that we realize that we have lean fat, we have fat mass, and not all. I don't know if we can call that having fat is good in any way. So earlier, I think there were two counter arguments to this, that you can have healthy obesity, but I don't think that, and we do realize now that the measurement of obesity itself may have been wrong in those arguments. And when you actually measure obesity by other standardized methods, then there is nothing known as healthy obesity. So you have obesity, you have adiposopathy, then that is okay. But about the syndromes, if you have, like are we talking about like lipodystrophy here, that you actually lose certain fat in certain areas, but you're not
Yes.
obese by
Healthy.
definition, but you have
Yeah,
all
but
the complications complications of the associated with
Metabolic disease.
metabolic disease.
So it can be both ways actually. So you might be losing weight like lipodystrophy in certain parts of the body, but that doesn't mean that you are healthy. Another example might be sarcopenic obesity, where the weight or the BMI comes down, but actually the fat percentage is going up. And the third thing might be in some ethnic groups, localized fat deposition, like steatopygia, that is a fat deposition on the buttocks. So in some tribes, or maybe even you can take kabaddi players and sumo wrestlers. They look obese, but actually it's all muscle that they have. So multiple syndromes are there, and that is the wide spectrum of barrow phenotype. Madam Ali Nazakat Saab also sending you a good evening. And now Dr. Anil Shinde has a question that's about motivation. That is the toughest part of obesity therapeutics. But Nazakat Saab says that during the holy month of Ramzan, people fast, and they have first they will have a very small or an okay kind of a breakfast, which is sahri. Then they will have a very heavy iftar. And so the question is, our topic is misconception. Is it the total calorie intake in the entire day which influences our weight? We're talking only about diet. Or can we say that I ate only twice a day, I did intermittent fasting for religious purposes or health purposes, and therefore I am allowed to eat as many calories as I want?
So actually, there was a very interesting study that looked at it. So there was intermittent fasting versus intermittent fasting plus calorie restriction. So intermittent fasting is you eat whatever you want in such, like, if you're eating for 12 hours a day, you eat, according to your wish for 12 hours a day only, or 10 hours a day only, and you do intermittent fasting for the rest of the time. And there was another group which looked at intermittent fasting plus calorie restriction. So you're looking at having a certain restricted calories in the amount of time that you're eating. So what actually matters for weight loss, for treatment of obesity, is just calorie loss or calorie deficit. So that is the only thing that matters. So if you're eating a certain amount of calories in, like, say 10 hours, but if you're eating the same amount of calorie in also 18 hours, then it is actually the same, because calorie restriction is more important than intermittent fasting. Of course, intermittent fasting has its benefits, but that is largely by calorie restriction only.
So, if at all there is this misconception, and the misconception is that if I do intermittent fasting, I can take as many calories or not. So, Madam is saying very clearly that's wrong. You have to restrict the total number of calories as well.
Correct.
Now we have Aditya Pannu, who, like I said, is a very young, handsome boy. So he was feeling weak. The chief complaint was weakness with other endocrine diseases, and in general, the diet is such that you often have protein deficiency. So what he says is that I took protein powder, and now I can run 4 kilometers at one time, and it gave me a lot of energy. So now multiple questions, myths, misconceptions. So if you could sort these out for us in Hindi and English mixed. Is protein deficiency common in India? जब हम पूरा खाना खाते हैं तो भी क्या प्रोटीन की कमी हो जाती है हम में? The second is कि हम प्रोटीन अपनी डाइट में कैसे बढ़ाएं? What can we eat in our diet, vegetarian, non-vegetarian दोनों में, ताकि प्रोटीन बढ़े? And third is what would be the indications for medical nutrition therapy? कि हम जाके अपने डॉक्टर से बात करें कि हमें लग रहा है हमें ज्यादा प्रोटीन खाना चाहिए. And madam, if three questions are not enough, a fourth question. ऐसी कोई diseases हैं? Are there any diseases where we should avoid taking extra protein?
तो थैंक यू सर। तो मैं इसमें अपने खुद का एग्जांपल देना चाहूंगी। तो मैं 2-3 साल के पहले आई वाज नॉट गिविंग मच ऑफ इम्पोर्टेंस टू डाइट। मैं उतना अपने डाइट के बारे में नहीं देखती थी। तो जब मैंने एक्चुअली देखा कि मैंने इन सब के बारे में मैंने ध्यान देना शुरू किया, तो मैंने देखा आई एम अ वेजिटेरियन। सो मैंने देखा कि मेरा प्रोटीन इंटेक तो बहुत कम है। स्पेशली साउथ इंडिया में हम ब्रेकफास्ट के लिए डोसा, इडली, उपमा ऐसे खाते हैं, फिर लंच के लिए चपाती राइस, डिनर के लिए फिर चपाती राइस। तो मैंने देखा कि मैं खुद मेरे खुद के डाइट में इतना कम प्रोटीन है। ऑफ कोर्स हम दाल वगैरह खाते थे, बट वो थोड़ा सा साइड में, राइस, कंपेयर राइस एंड दाल, तो दाल तो बहुत ही कम। तो आई रियलाइज दैट मेरे खुद का डाइट वाज ऑलमोस्ट कार्बोहाइड्रेट एंड देयर वाज नो प्रोटीन एट ऑल। एंड मैं मेरा वेट बढ़ रहा था, एंड आई वाज आल्सो फीलिंग वेरी वीक एंड लेथार्जिक आफ्टर अ हाई कार्बोहाइड्रेट डाइट। सो मतलब हमारे डाइट में एक्चुअली प्रोटीन बहुत कम है. If all of you actually calculate your protein intake, unless you pay attention to it and make efforts to increase the protein intake, it is actually very low. क्योंकि especially in vegetarians, क्योंकि मतलब ours is a predominantly carbohydrate based diet. मतलब सालों से ऐसे ही आ रहा है कि मतलब हम ब्रेकफास्ट में, लंच में, डिनर में ज्यादातर कार्बोहाइड्रेट्स ही खाते हैं. एंड प्रोटीन कैसे बढ़ाए अपने डाइट में, तो अगेन मैं खुद का एग्जांपल देना चाहूंगी. तो आई एम अ वेजिटेरियन. तो मैं ब्रेकफास्ट में आई कैन नॉट रिप्लेस माई ब्रेकफास्ट विद एनीथिंग एल्स. आई वांट टू हैव डोसाज, आई वांट टू हैव इडलीज, बट आई आल्सो वांट टू हैव प्रोटीन. सो मैंने ये मतलब आई सर्च फॉर अ लॉट ऑफ रेसिपीज, स्पोक टू अ लॉट ऑफ डाइटिशियंस, डिड माय ओन रिसर्च एज वेल. तो मेरा अभी खुद का ब्रेकफास्ट इज एन एक्सक्लूसिव प्रोटीन ब्रेकफास्ट. तो मैं क्या करती हूँ, साउथ इंडिया में हम ज्यादातर मतलब वी लाइक डोसास. तो मैं इंस्टेड ऑफ राइस डोसा वी हैव मूंग दाल डोसा या बेसन का चीला, तो मेड आउट ऑफ फ्लोर और मूंग दाल. तो डोसा इज रिप्लेस्ड विद दैट अगेन विद vegetables. So there I have added some protein. And for lunch, so I say that I always tell my patients that the amount of rice that we eat and the amount of dal that we eat is so disproportionate. So we are eating 90% rice and only 10% of dal and other vegetables. So like you eat rice, you eat dal and you eat first. So you eat your salad first and then you eat dal first and then you go on to your carbohydrate. So automatically your carbohydrate intake comes down. So you have to make that effort to see that lunch में भी दाल है, dinner में भी थोड़ा सा. मतलब dal is not a very good source of protein, but it is one of the sources of protein for vegetarians. One more thing that I have incorporated in my diet and is also very good source of protein is soya. So I have been making parathas out of soya chunks. So I buy the soya chunks, boil them, make them into a dough, and you can actually make parathas out of it. So this is my dinner every day now. So earlier I used to have wheat parathas, and now I have soya chunk parathas, and they're actually tastier. So and I also take supplements now and then. They are, when I'm not able to follow a strict protein intake, the protein requirement per day, I also take supplements. The supplements that I know are good to take and are not adulterate. So that is also good to take if you're not meeting a protein requirement through the dietary requirement itself. But for non-vegetarians, it's much easier, I would say, because you also have meat, eggs, and other sources of proteins as well. So definitely, I have tried to improve my protein intake in the diet since the last 2 to 3 years, and it's definitely possible by roast or. And sorry, sir, the third question was like, if you have protein.
Indications, yeah. So let's just summarize this. मैडम ने तो बहुत अच्छे आइडियाज दिए. तो आप दाल की चपाती, दाल का परोठा बना सकते हैं और दाल या सोयाबीन का परोठा भी बना सकते हैं, which is a great idea. Madam has mentioned about soybean, and actually जो white soybean है, ये second best. This is the second best source of protein amongst all the dals. The best is something called black soybean that comes from Uttarakhand. हिंदी में उसका नाम है भट की दाल. और वो धीरे धीरे पकाई जाती है जैसे माँ की दाल को पकाते हैं. It takes a few hours more to cook it, but anybody who is able to access it, bhat ki dal would be a very good source of protein, and white soybean to hai hi hai. So thank you, ma'am, for all these ideas, and even I am inspired now to get my dinner changed. And
Thank you.
पन्नू बेटे, for you as well, मतलब घर पे बोल सकते हैं कि सोयाबीन चंक्स लें. From a North Indian perspective, I would like to talk about the difference between soybean chunks and soya chap. जो सोयाबीन चंक्स हैं वो ब्राउन कलर के आएंगे, वो प्योर प्रोटीन है, उसमें सोयाबीन है. मगर जो आप सोया चाप खाते हैं जाके एज अ स्नैक या डिनर में खाते हैं, जो व्हाइट कलर या अलग अलग कलर्स का है, उसमें 80% मैदा है और 20% सोयाबीन है. नाम उसका लिखा गया है सोया चाप, तो वाकई सोया है, पर वो ये लिखना भूल गया कि इसमें सोयाबीन सिर्फ 20% है और मैदा 80% है. और क्योंकि मैदा है इसलिए उसका टेस्ट अलग है, बेटर लगता है. सो द सोया चंक्स इज व्हाट यू शुड eat. And soya chap, of course, if you want to eat for taste, that's fine, but don't think that it is a very healthy source. The next two questions, madam, were what are the indications for medical nutrition therapy? Hum protein powder kab lein? And are there any contraindications? Are there any patients who should avoid taking medical nutrition therapy or medical grade protein?
So the indication would be simple, sir. मैं मतलब सबको यही बोलती हूँ, अपने पेशेंट्स को भी यही बोलती हूँ कि आप आपके रोज के खाने में प्रोटीन रिक्वायरमेंट अगर नहीं हो पा रहा है, तो some people cannot make these things that I suggested, and they are not able to meet that requirement through their daily food, then medical nutrition therapy or taking a supplementation would be advised. So पहले हम देखते हैं कि आपके मतलब रोज के खाने में आप जो खा रहे हैं उसमें प्रोटीन रिक्वायरमेंट कितना, प्रोटीन मतलब कंटेंट कितना है, आपका रिक्वायरमेंट वो पूरा कर रहा है कि नहीं. अगर पूरा कर रहा है तो यू डोंट नीड एनी सप्लीमेंट, बट अगर पूरा हो नहीं पा रहा है तो ऑब्वियसली यू नीड टू टेक अ सप्लीमेंट. And so that would be the indication for a medical nutrition therapy. And there is there are per day requirements. So if you meet an endocrinologist, they will tell you that per day requirement, for example, would be 1 gram per kg or 1.2 gram per kg protein. But if somebody has a chronic kidney disease, अगर किसी को किडनी का प्रॉब्लम है, तो दैट रिक्वायरमेंट मे बी लोअर इन later stages of chronic kidney disease or earlier
Yeah.
stages of chronic kidney disease. It depends on the stage of disease. तो उनमें थोड़ा सा हमें ये देखना चाहिए कि मतलब ज्यादा it does not go overboard. But as of now, when I see all the chronic kidney disease patients, they are so deficient in protein, so it is difficult to go overboard in them as well. And also one thing is like many protein powders are adulterated, so हमें पता नहीं चलता कि इसका कंटेंट क्या होता है. तो बहुत लोग जिम जा रहे हैं, प्रोटीन ले रहे हैं, उसमें बहुत सारे मतलब अडल्ट्रेशन भी हो सकता है, जैसे कि स्टेरॉइड्स. Some people in the gym can adulter your protein powders with certain things, so you have to be careful to take good brands and make sure that you're taking a good protein and not anything else with it if you're taking supplements.
सो थैंक्स अ लॉट. एंड अब देखो हमारे एक-एक करके मिसकंसेप्शंस अब दूर हो रहे हैं. एक तो डायग्नोसिस या डेफिनिशन ऑफ ओबेसिटी, एडिपोसिटी. दूसरा डाइट की हमने बात की और प्रोटीन की, व्हिच इज एक्चुअली द मोस्ट इम्पोर्टेंट थिंग. इंडिया में सब लोग बात करते हैं, एवरीबॉडी टॉक्स अबाउट रिड्यूसिंग कैलोरीज. तो रिड्यूस तो करेंगे, बात सही है, बट रिप्लेस भी तो करना है ना किसी चीज के साथ. यू कांट गो टू जीरो कैलोरीज. तो यदि हम अपनी प्रोटीन इंटेक बढ़ा देते हैं तो ऑटोमेटिकली हमारी भूख भी कम हो जाती है. एंड लाइक गुरुदेव जी या आदित्य पन्नू सेज, इट गिव्स अस मोर एनर्जी. द प्रोटीन गिव्स मोर एनर्जी, you can work better. We have a question from Dr. Mukesh Makrolia, but before that, let's take one other misconception. Now, Aditya says, now I can run 4 kilometers at one time. So, the question is, what is correct, what is wrong, or is there an answer in between? Everybody should run 4 kilometers at one time every day to lose weight. The same kind of exercise should be advised to everybody. And then there is something called the aching knees paradox. So, you are obese, your doctor tells you to run to lose weight so that your knees become relaxed. You get less pain, you get less osteoarthritis. But on the other hand, when you begin running, let us say you begin 20-30 minutes of treadmill, your knees worsen actually because you don't sort of follow the right rules of running. So how do you navigate this? How do you exercise and take care of your knees at the same time?
So this is something that I learned from you, sir, in many of your talks and also your advice to many of us, that whatever you start slow. ऐसा नहीं कि मतलब I know that we have spoken of this example many times. So somebody with diabetes and has high cholesterol come to us, and then we tell them आज से तुम ये गोली खाओ, स्टैटिन भी खाओ, आज एक्सरसाइज भी करो, ये भी करो, डाइट भी स्टार्ट करो, आज से सब कुछ स्टार्ट कर दो. That patient can have statin induced rhabdomyolysis also if we start all of this together. तो मतलब इसमें ये करना है कि we have to start in steps. तो मतलब आपने ये जो weight gain किया है, this is over the years. So obviously there you have to realize that it takes some months to get to lose some body weight. तो हमें पहले से we have to have goals, achievable goals, and not they need not be immediate. They may be different for different people. So based on feasibility, मतलब किसी को ज्यादा टाइम है स्पेंड करने को, किसी के पास टाइम नहीं है कि कोई डाइट मतलब they cannot follow so strictly. So it depends, and it's always patient centered. So there is nothing that one size fits all. If Aditya is able to run 4 kilometers, then it's good. If somebody is able to run 6 kilometers, then that is also good. But if somebody is not able to run 4 kilometers today, then we can build up build it up in a few days. So we can start with 20 minutes, we can start with 15 minutes, we can start with walking. So even walking is better than sitting. So running is good, but even walking is better than sitting. So all most of my patients who have obesity have knee pain, osteoarthritis as well. और मतलब उनके लिए मैं ये एडवाइस देती हूँ कि मतलब व्हेन यू स्टार्ट डाइटिंग एंड व्हेन यू स्टार्ट इंक्रीजिंग योर कार्बोहाइड्रेट डिक्रीजिंग योर कार्बोहाइड्रेट intake in the diet, your weight comes down. And when you lose 5% of your body weight also, so another myth is you have to lose like 20 kgs, 30 kgs, 40 kgs, to have that relief from weight loss. तो ऐसा नहीं है. तो आप अगर मतलब if you want to see some results of weight loss, for example, if you want to see a reduction in knee pain, you only have to lose 5% of your body. So 5%, if somebody is 80 kgs, तो 5% हुआ 4 kgs. तो 4 kgs तो हम डाइट एंड थोड़ा सा वॉकिंग में भी हम अचीव कर सकते हैं. ऐसा नहीं है कि उनको भागना ही होगा और ट्रेडमिल पे ही भागना होगा और आज भागना होगा, ऐसा नहीं है. तो it is achievable, small goals are achievable, and it will take time, and we need to go stepwise.
I think that's important information for all of us, stepwise. And एक एक बूंद से सागर भरता है. With each and every drop, you are able to create an ocean. और ऐसे ही एक एक एक्सरसाइज से, एक एक स्टेप से, फाइनली आप गुड हेल्थ तक पहुंचेंगे, फिटनेस तक पहुंचेंगे. बट ऑल दो स्टेप्स डोंट हैव टू बी टेकन इन वन डे. And also remember that it has to be done every day. So it is better to be consistent. Let's say you are able to do 5,000 steps every day, and once in a while 10,000 steps. That is better. Instead of saying today I'll do 50,000 steps, and then tomorrow I won't do anything. Good evening, Ara ma'am. Aapko from Vinayak Sharma ji and Dr. Narinder Singh. And Dr. Mukesh has a question. He says, I have an obese patient with high LDL. Patient is not improving with low dose statin. So the question is, number one, should I shift to high dose rosuvastatin 40 milligram or atorva 80? Or should I add another drug like bempedoic acid or ezetimibe or both of them?
So we can, do the risk assessment of the patient. There are various risk, assessment tools available online, and based on the risk assessment of the patient, other factors like family history of cardiovascular disease or diabetes or in smoking or all other risk factors together, you get the risk for that patient and the target LDL. So if the patient is not achieving his target LDL, you go to the, if he's on low dose statin, obviously we can increase the dose of statin to the maximum tolerable dose. And with that, if the targets are still not met, you can add, another drug which can help in LDL lowering. So this is the standard teaching, but nowadays we have evidence to say that you can actually start other drugs earlier than need not have to wait for to go up to the highest dose of statin and see if the patient is meeting the target or not. You can actually start these drugs much earlier, and they seem to have better outcomes. And we did one such meta-analysis and said that if you start these drugs immediately after ACS, like they have better outcomes than rather than starting later on during the course of treatment. So there are two schools of thoughts, and I think we have mounting evidence to say that you can actually start them early.
So, Dr. Mukesh, feel free. And of course, first of all, we need to achieve target. Target can be defined in terms of specific numbers, and also even a target like you can tell the patient if we've been able to bring your LDL down by 30% from baseline, that will also be helpful. And in case you're just not getting anywhere with all these drugs, then that is an indication for checking for familial hypercholesterolemia. And we can use drugs like evolocumab then. And then there is another drug that I myself has not used, inclisiran. So these are drugs which will help in these refractory kind of dyslipidemia patients. So when we've talked about the diagnosis, we've talked about diet and exercise. Uh, and of course, many times on KK Med Talks, we've talked about drugs. But there is one thing that brings all this together, and that is motivation. So we come back to this question from Dr. Anil Shinde. Uh, his question is, most of people deny that they are overweight or obese. So, first question, we can take all this together in free-flowing discussion. Is this common in your OPD, denial phenomenon? Second is whether you do a waist circumference or a BMI, they will always have an excuse. Yeah, I went to a marriage last night, or it's been Holi season, or Diwali season, or Pongal, so that's why my weight is up, or maybe I'm wearing heavy clothes. So is that also common? If you have denial phenomenon, what are the common reasons that people take? And once we are able to answer this, the why of why people deny, then we can move on to his next question, which is how do we overcome this? How do we motivate people to lose weight?
Thank you, sir. So I think this is very common in my OPD. People don't, first of all, I mean, forget about patients. I think many of healthcare providers also don't recognize obesity as a chronic disease which has consequences. So, for example, we take MI and we talk about risk factors for myocardial infarction. We talk about diabetes. We talk about dyslipidemia. We talk about hypertension. We talk about achieving these targets. We talk about LDL less than 70. We talk about blood glucose. We talk about BP targets. But have you ever talked about weight loss and achieving those weight loss? You know that obesity is a risk factor for myocardial infarction. Obesity is a risk factor for heart failure. But we never talk about treating obesity to treat these diseases. So I would say that there is ignorance even at the level of healthcare providers, and at the level of patients, it is very prevalent. If it's very difficult to bring up the topic of obesity also, because people come to you with other things, right? They come to you with knee pain, they come to you with difficult to control diabetes, they come to you with obstructive sleep apnea, but nobody will come to you and say कि मुझे लग रहा है कि मेरा weight ज़्यादा है और इसलिए मेरा health affect हो रहा है. तो most of the people who come to me for treatment of obesity itself are for cosmetic purposes. So somebody wants to attend marriage function, somebody is getting married, so they come and say that we want to lose weight for this thing, for cosmetic purposes, not for health purposes. So I think that there is a lot of misconception among patients also, and they think that obesity is a cosmetic problem, and that's why they are in denial. और बहुत सारे लोग बोलते हैं कि मैं मतलब जैसे आपने बताया कि कल शादी था, तो कल एक देयर वाज अ फेस्टिवल, अभी तो दिवाली सीजन चल रहा है, तो ऐसे चलते ही रहता है. तो दे आर नॉट वेरी सीरियस अबाउट टेकिंग. I think that they don't realize that the consequences of obesity. So if you see a patient, for example, who is overweight, has obesity, has diabetes, hypertension, obstructive sleep apnea, osteoarthritis of the knee, all of this can actually be treated by treating obesity. So we know that diabetes remission is something that can happen. Hypertension remission also is something that can happen if you're treating all of this. No, you're looking at the root cause of most of it, which is obesity. और पेशेंट्स को कैसे मोटिवेट करते हैं, तो आई स्ट्रगल्ड अ लॉट विद दिस, एंड नाउ आई ऑल्सो टोल्ड यू सर रिसेंटली व्हेन आई मेट व्हाई आई हैव फाउंड अ हैक फॉर दिस, एंड दैट इज गेटिंग इन टच विद द पेशेंट डेली. तो जो पेशेंट्स मेरे पास वेट लॉस के लिए आते हैं, वो रोज मुझसे बात करते हैं, रोज मुझसे या मेरी टीम से रोज बात करते हैं, एंड रोज हम उनको मतलब अकाउंटेबल रखते हैं कि व्हाट दे हैव डन टुडे. So they feel very motivated because somebody is talking to them every day. So they also feel happy. और हम पहले ही उनको बोल देते कि यू हैव टू लूज 5% ऑफ योर बॉडी वेट. मैडम आपका वेट 90 केजीज है, तो आपने अगर 4.5 केजीज लूज किया तो आपका डायबिटीज का गोली बंद हो सकता है, आपका हाइपरटेंशन का गोली कम हो सकता है या बंद भी हो सकता है. आपने 9 केजी लूज किया तो डेफिनेटली बंद हो सकता है. तो अगर आपने 9 केजी लॉस मेंटेन किया तो आपको गोली गोली लेना है, मतलब यू डोंट नीड टू टेक द मेडिकेशन गोइंग फॉरवर्ड. तो जब हम ये बोलते हैं, when I talk to them about coming down on medications, many people actually feel motivated because all of us don't like taking medications. So that is one thing. And another hack is, daily messages, daily, daily conversation with patients. I think that has helped me to some extent in my practice.
So the trick that Madam is saying is being in touch with each other and being in contact, like hand holding and like continuously motivating. So there will always be ups and downs, but if there is someone with you, a friend with you, then you feel more motivated. And we call this, Dr. Lakshmi, we call this the barrow buddy style, barrow from weight. So barrow buddy can be your doctor, it can be your healthcare team. And we welcome रेखा बिटारा मैडम. रेखा मैडम भी दिल्ली से हैं और ये हेल्थ केयर प्रोफेशन में हैं. तो इनका काम जो है वो हेल्थ बडी या हेल्थ सखी वाला है, इन अ वे हेल्थ फ्रेंड वाला. And barrow buddy can also mean that alone you feel afraid or you feel shy going to the gym or you feel demotivated. But अगर आपके साथ कोई दोस्त हो, कोई सहेली हो, कोई रिश्तेदार हो, उनके साथ आप जाएं, that becomes your gym buddy or your barrow buddy, and then suddenly the gym also becomes enjoyable. ऐसा भी नहीं that you have to go to the gym, you can also go for a walk, you can go for a run. अकेले दौड़ो तो अलग अलग फीलिंग आती है, बट अगर आप अपने दोस्त के साथ दौड़ रहे हैं तो अलग फीलिंग आती है. So that is barobody. So, ma'am, so many things we've talked about. We've talked about definition, diet, exercise, and motivation, which is the toughest part. And then this misconception that you had spoken about, metabolically healthy obesity, doesn't exist. Even if it does, it is cross sectional, it is transient. Sooner or later, the complications will come. And Dr. Mukesh also recognized that. That's why Dr. Mukesh was proactive. The patient has high LDL. We want to bring it down so that there are no complications tomorrow. Uh, let's talk about one more misconception, and that is the society as well. So, who causes obesity? I live with obesity. Is it all my fault? Can I put all the fault on the society and environment around me, or again, will the answer be something in between, even though it is not palatable to me?
So I think the answer is in between, sir. But if you ask me honestly, like maybe 10 years back, if somebody asked me when I was doing my MD, why am I gaining weight? It's just we would just blame it that you're not moving, आप exercise नहीं कर रहे हो, आप ठीक से खाना नहीं खा रहे हो, तो इसलिए आपका weight बढ़ रहा है. So this was our thinking 10 years back. But now we know that that is one of the causes for obesity. It's not just about your diet and lifestyle. Of course, it's a very large part about your diet and lifestyle, but we also have genetics which can predispose you to obesity. And मेरे सारे पेशेंट्स बोलते हैं कि मैं जितना खा रही हूँ, मेरी कजिन भी इतना ही कर रही है, मेरी फ्रेंड भी इतना ही कर रही है, और वो भी इतना ही एक्सरसाइज कर रही है, तो आई एम पुटिंग ऑन वेट, व्हाई इज शी नॉट पुटिंग ऑन वेट? So matlab, I think the explanation goes a long way, that there's got so much more to do than just what you eat or how much you move. And genetics plays a very very big role, I think, in uh, pre it's already determined that how you're going to process all these things. But you can very to a very large extent treat it and also control it by your lifestyle.
So every person is different, and that is very well said. तो सभी लोग अलग हैं और सभी की अपनी अपनी जिंदगी है. एंड अगर कोई ओवरवेट से के साथ रह रहा है या ओबेसिटी के साथ, हमारा काम है उससे लड़ना and to try to minimize that and its complications, and each and every person will have his or her own journey in life. That's very well said, and I think if we understand this, madam, then all the myths and misconceptions, they automatically fall into their own place. Then you understand that each and every person is different. We also face this problem in the OPD. So ladies will come and say, why is my thyroid medicine 100, but you gave only 50 to my neighbor? So do you face that problem in your OPD as well?
रोज सर, रोज रोज यही पूछते कि आपने मुझे 2 गोली दे दिया डायबिटीज के लिए, उसके तो मेरे हस्बैंड का तो एक ही गोली है, मेरे लिए क्यों, आपने 2 गोली दी? मैं खुद मतलब खाना बनाती हूँ, मैं पकाती हूँ खाना, और मैं कम खा रही हूँ, बट फिर भी मेरे शुगर ज्यादा है मेरे हस्बैंड से, तो ऐसे क्यों हो रहा है? तो आई थिंक everybody's journey is different, everybody's condition is different. And now we recognize that even with type 2 diabetes, the clusters are so different. Already 6 clusters are there, but I think there are much more than that. I think there are at least 20 clusters that I
Wow.
know of in diabetes. And so what I would like to say is nothing is right or wrong. अगर अगर मतलब ये मतलब some the most often asked question to me is taking मेडिकेशन फॉर ओबेसिटी रॉन्ग? मतलब मैंने एड में देखा कि एक इंजेक्शन आ गया कि ओबेसिटी के लिए इंडिया में भी आ रहा है, तो ये लेना क्या गलत है या सही है? तो उसने लिया, मेरे कजिन ने लिया यूएस में, तो मैं ले सकती हूँ. मतलब देयर इज नो राइट और रॉन्ग फॉर एवरीवन. सो द इंडिकेशंस आर डिफरेंट फॉर एवरीवन. सम पीपल विल डू वेल विदाउट मेडिकेशन, some people will need medication to reach their target. So nothing is right or wrong, and it is always that you have to find what works best for you and for your patient.
There's one question, and this comes from Dr. Vani Gulati. She's an ENT surgeon in Bangalore. What she says is that I am doing very well on an anti-obesity medicine. I'm very comfortable with life. Now I'm going to get married. So she has multiple questions. First of all, can I stop the drug suddenly? it's an oral drug that she's taking, or should I taper it off? Can I stop it for a few days during my wedding? There will be so many things going on, and how will I remember to take the tablet at the right time with the right amount of water? And then the third thing is, what about planning? Let us say a lady is planning a family. Then what should she do if she is on any obesity lowering tablet or injection? Some of these are available in India, others are available abroad.
So thank you, madam, for that question. And जैसे कि मतलब we have spoken about this many times. कि obesity is a chronic disease. तो मतलब जैसे कि हम डायबिटीज के बारे में बोलते हैं, जैसे कि हम हाइपरटेंशन के बारे में बोलते हैं, जैसे कि आप मतलब डायबिटीज के लिए तो अगर कोई गोली ले रहा है तो to a large extent that the it is controlling his blood glucose level, still he is taking the tablet. So obesity is also like that. It's also a chronic condition. Then till you're taking the medication, your weight, comes under control, or you maintain that weight loss that you have achieved. But suddenly stopping the drug may not be a good idea, because you can have the weight regain, and it could be quite sudden as well. About tapering and stopping, I'm not very sure if we have much evidence on this, whether tapering and stopping is better than stopping alone. But what I do know is that once you stop the medications, the weight regain will be there. So obesity, what we need to understand is it's like a chronic condition, like all the other conditions. Like if you're taking medicines for hypothyroidism, then your thyroid levels are under control. So if you're taking medications for obesity, then your weight is under control. So it is a chronic condition, and you will need to take medications. And if you're planning pregnancy, if somebody who's planning pregnancy on anti-obesity medications, as of now, they need to stop it before planning a pregnancy, because we don't have safety data for these anti-obesity medications in pregnancy.
It's a good idea to stop 3 to 6 months before planning pregnancy. Don't like plan in such a way. If you're going in a planned manner, don't plan that I'll stop just one day before or 1 month before planning pregnancy.
Correct.
So, ma'am, it's been great being with you. So many difficult aspects of obesity you've handled for us, and you've made them so simple. So now we have a fair idea. If we are living with obesity, we know that we need to take action, and we know that we need to show the right doctor, the right healthcare professional. So, this is the last question that we'll ask. Can any single healthcare professional handle my obesity, and whom do I go to? Who is the team leader in obesity management?
So I would say you.
Though, yeah, I have the lived experience, so that is something that I feel very proud of. That I have the lived experience, and right now I'm on the right path. My weight is going southwards, so I feel happy. I am grateful to my team leaders, people across the country. If I start from north to south, Dr. Suneet Verma in Panchkula, Dr. Lakshmi Nagendra in Mysore, Dr. Nitin Kapoor in Vellore, and Dr. Mohan T. Shenoy in Trivandrum. Everybody works hard to keep my weight under control. Right now, they're doing a good job. Dr. Atul Dhingra is also there in Rajasthan, so everyone contributes. So,
I
but
would say that, but when we gain weight, what we didn't speak about is important to lose, to rule out secondary causes of weight gain. So we know that certain endocrinological disorders like, say, Cushing's disease can actually lead to weight gain. So very important, especially if there's sudden weight gain, to rule out these, secondary causes of obesity, because if you treat them, then, you are treating the obesity. तो वो तो पहले, like I would say कि you have to see an endocrinologist, just to make sure that you don't have any underlying cause. But by one person treating obesity, I think we would all agree that it's a team effort. No one person can treat obesity. Even in my clinic, it's a team effort. So I would say you will require the help of an endocrinologist. You will require the help of a nutritionist. You might require the help of a psychiatry team sometimes for motivational behavior. You will also need help of a bariatric surgeon if there is indication for bariatric surgery. But I think an endocrinology actually can be at the helm of all of this, to kind of get the patient into onboard the patient into this journey, and make sure that they are in touch with all the appropriate healthcare providers.
Swapna Jain ji says the same. She says you should reach out to an endocrinologist or a bariatrician. And of course, multiple people may be required, like you're going on a journey. So you might have different Humsafars companions at different times. but the person at the helm is actually you yourself, the person living with obesity, and your endocrinologist can help you only as much as you allow him or her to help you. I'd
Correct.
also like to take the name of one more person, Dr. Lakshmi, who's been helping me, and Madam is Dr. Deena Shrestha from Nepal. So she's also been a great source of motivation for me. And then my children as well, who lead by example, Arnav, Kriti, and Khyati. So they also motivate me and make sure I remain, focused on my task of healthy eating. But talking about focus,
So
Swapna
right
Jain ji has,
now, so
yeah,
sorry, are you standing?
yes. So
So
all my talks are done standing.
yeah, so I think that I something that I have to incorporate, and I'm learning from you right now that this is 1 hour that I could be standing where I'm sitting. So I think
Yes,
yeah.
standing and little bit of ankle movement as well, which I forget. So that keeps the circulation going. Uh, okay, so talking of ankles, uh, one very beautiful message first from Swapna Jain madam, and then a question from Ramji Agarwal sahib. Swapna Jain ji कहती हैं, fit. If you want to remain fit, you just forget incorrect theories. That's the best way. So you overcome the myths and misconceptions. And she has summarized your talk in such a beautiful, lucid way for us. Uh, so S is for Swapna and S is for sapid, a word which I learned recently. S into everyone who is logged in, इस English word का क्या मतलब होता है? Sapid. और जब हम बात करते हैं sapid स्वप्ना जी, तो हम स्वप्ना मैडम की तारीफ कर रहे हैं या बुराई कर रहे हैं? ये भी एक क्वेश्चन है. अब तारीफ करने के लिए भी ना इफ यू हैपन टू बी अ मिडिल एज्ड मेल इन इंडिया तो कम तरीके हैं तारीफ करने के, बट दिस इज अ सोशली एक्सेप्टेबल तरीका. सो SAPID का मतलब क्या होता है? तो मैडम बोलती हैं, जैन मैडम बोलती हैं, गो विद द फ्लो, डोंट रश, slow and steady wins the race, and you just lose 5%. So just flow 5%, remain fit, and say goodbye to metabolic diseases through this way. Understand that you are unique as a person, and a person centric plan will work. तो अगर आपके डॉक्टर आपके लिए पर्सन सेंट्रिक प्लान बना के देते हैं और आप उस पर अमल करते हैं और आप फिलहाल टारगेट करें that you will lose 5% of weight in a few months, then automatically you will find yourself on the road to good health. So thank you, Jan madam, for this. There's
Thank you,
one
madam.
question. Yeah, we were just speaking of ankle movement. तो अग्रवाल साहब says, क्या मोटापा बढ़ने से foot drop हो सकता है? Can you have foot drop as a complication of obesity?
Mm, it's not a very common complication I
Common.
would say that I've seen. Yeah, but I don't know. Can it cause by you know?
Entrap There might be an entrapment, sir, but तो आपने सवाल जो पूछा है, अब देखो हम दोनों स्ट्रगल कर रहे हैं, क्योंकि इमीडिएटली कोई पेशेंट नहीं आ रहे हैं जहन में जिनको फुट ड्रॉप हुआ हो बिकॉज ऑफ ओबेसिटी, बट सर्टेनली देयर इज ओबेसिटी रिलेटेड न्यूरोपैथी, नर्व्स वीक हो जाती हैं, एंड एंट्रैपमेंट सिंड्रोम एक होते हैं अलग अलग नर्व्स में. तो अगर वेट कम कर दें तो सर्टेनली फुट ड्रॉप के जो रिजल्ट्स हैं वो बेटर हो जाएंगे, उसमें तो कोई इशू नहीं है. But whether it directly causes foot drop or not, we'll get back to you by next week. That we can promise. And that is the best thing, Dr. Lakshmi, about KK Med Talks. You meet so many people. 1 + 1 becomes 11. अब देखो रामजी साहब ने सवाल पूछा, so it has motivated us now to go back and read and to do research, and maybe it will help someone else.
Correct. So
Aditya
I
Panu
think
says, yeah.
so please
Aditya
go ahead.
Panu says, thank you to you for everything that you've taught him today. He's our young, handsome boy who runs 4 kilometers every day, and he's
Thank you,
building a
thank
lot of
you,
muscle.
thank you, sir. Pleasure having your questions. I mean, it became so interactive because of you. Thank you.
We have Sriyan with us backstage. Sriyan and her colleagues, Sriyan और इनके जो दोस्त हैं, colleagues हैं, ये हमारा ख्याल रखते हैं. इन्हीं की वजह से हम KK Med Talks आपके लिए ले पाते हैं. And Sriyan also juggles with multiple things at home and at work, and that is why she is able to remain fit. But let's ask Sriyan, आज आपने क्या सीखा? Anything new that you have learned? Any myth or misconception of yours that has been dispelled today? Any other myth or misconception which you still feel exists in the community?
Yes, sir. So from I think today's session mainly highlighted on the misconception around obesity and healthy living, emphasizing the importance of balanced diet, regular physical activities, and also personalized approach to sustainable weight management, which we do not regularly do in our lifestyle, basically because of our work schedule and all. We miss these things. So, and also today's session addressed on the myth surrounding metabolism, like quick fix diet and the role of genetics as well. I also got to know about that genetics plays a huge role as well. So that's all I've learned from today's session, sir.
Thank you so much. And Sriyan, can we show a certificate of appreciation for Dr. Lakshmi, please? Thank you so much. Thank you, Dr. Lakshmi, for being with us. It was great having you. And I have also learned so much, so many things that you've simplified for us. And
Thank you.
from people who've logged in from across the country, from north to south, east to west, सबकी तरफ से एक बहुत बहुत शुक्रिया, तहे दिल से धन्यवाद, मेहरबानी. And if you know, in Haryanvi, we don't have a word for thank you or shukriya. These are all loan words that we borrow from Punjabi, Urdu, and Hindi. So the closest that we get to in our state is Thara Bhala Ho, which means Aapka Bhala Ho. May all be good with you. And the answer to that actually is in a greeting, the answer is Sabka Bhala Ho. May things be
Hello.
good.
Yes,
Yes.
that was great.
And
Thank
Sabka
you so
Bhala
much.
Ho. Thank you and Jai Hind, madam.
Jai Hind, sir. Thank you.